Folks, grab your coffee, find a place to sit down. It's a little crowded in here, which I think is fabulous. So I think we're going to go ahead and get started. We have an ambitious day for timeline and so much to cover, so we're going to try to keep us moving along. But I just wanted to kick us off. I'm Rebecca Cunningham. I'm our interim vice president for research here at the University of Michigan. I'm also on the leadership team and one of the PIs of our FACS grant here, and I cannot be more thrilled to start having this conference here today. We came together as a group with our funding. We're in our beginning of our third year now to address this, the second leading cause of death among kids and the leading cause of death among our high school age kids in the country. And to really start to build capacity in the field. And for that, I am very grateful. We have our funders here, our project officer, Dr. Mel Holmes, for the NICHD to help us build capacity for this, and recognizing the issue that it is and the problem of death among the kids in our country and how we can come together to work on them as a field and as science. And we have been working steadily on that over the past couple years, and seeing all of you here together today and knowing that there's about another 150 people on live stream as well. It's just really a very historic moment. It's really a dream. When I think about 5 years ago that I could have named and about all 6 people who were continually working on this field, some of whom are in the room on one hand, maybe 10, that now this together, this is a field. This is a field that's growing, and in the conversations we've been having over the past year, we're starting to think about the basic science again and the measurement of that in the way that we think about any other science with all of the politics aside, and we get to just think about how we measure the outcome variables and what's the significant outcomes and what we should be thinking about for study design, the same way we think about any other of our injury science problems, and to me that is tremendous success. We worked really hard today to have this conference be really just a science conference. I very purposely did not have press or anyone else engaged. We really want to have a conference where we get to do the old-fashioned thing where we come together and as injury scientists together, talking about firearm injury prevention, working and mulling over the issues together and coming to solutions. We have many of our stakeholders in the room as well, thinking about a vast amount of perspectives and how we can work together on the problem. We have over 30 states represented. We have people from all over. I was delighted to see when we had posters, when we put a call out for posters, I thought we might get 20. The field is small. We have almost 50, and we have people from all over the country coming. So today will be a time of learning and networking together, a time to talk about firearm injury prevention science like any other science conference. We know that as we see this rise in death rates, and our speakers will talk about those today, we know that we have to do something to start to address this, and that firearm research is not only allowed but needed. There's certainly no ban on this. There's not enough funding, but with the funding that we do have, thank you very much from the NIH, as well as with the other funding that people have cobbled together, as well as their volunteer time and efforts and internal resources, we are beginning to build that field. And firearm research is 100% injury prevention. Firearm injury prevention research is completely needed, and we really must. And I think when I look at this group today and know all the many more people that are watching on live stream, we know we're way past a tipping point for not having this be a field. This field is only going to continue to grow. We will have another conference next year. I think we're going to need a room twice the size. I really hope we will. I see that happening. So together we're building the field, and these new initiatives with several people in the room are sort of metastasizing and building upon each other. We now have leaders in the room from many other centers. There's a center in New Jersey on firearm research. There's a center in California. There's a center in Washington. This is growing. And by working together is the way that we will do this. I want to give a call out here. Our FACS team here is a leadership team led by Dr. Mark Zimmerman, can stand, yes, and Dr. Pat Carter. Also, I don't see Lynn Massey and Lainey here, yeah, who have been responsible for all of the logistics and the glue of pulling off both this event as well as a lot of our work together. For those of you who are new to FACS, and I have our website up here, in our first 2 years, we accomplished much of our work, which was around capacity building, to put up a to develop together a research agenda for the field for children and adolescents, and you can find that on our website, as well as reviews of the literature across risk and protective factors, primary and secondary prevention, policy, what is known, what is out in the literature, and that our group of content experts has reviewed. We also have on here a data repository on our website where we have almost 100 data sets archived that are publicly available and downloadable for students and trainees and junior faculty and any of you who want to dig into the science and see what is already out there. I'm also really excited that when I talked about the field growing and metastasizing, that this 2 weeks ago that President Schlissel here at the University of Michigan announced that the University of Michigan will begin planning for a full campus-wide firearm injury prevention research initiative so that we can build the full capacity of our scientists across the University of Michigan to be focusing on this research and public health problem. And as we do that, and as we see other schools and colleges across the country begin to focus on this, we hope that your schools too, as they have taken up the cause for transportation safety with 30 centers across the country, with cancer research, with almost a research institute for cancer on every campus, that your campuses, wherever you are too, will also start to make this a priority area given the leading cause of death that it is among our children. And so now I would like to turn over the podium to Dr. Zimmerman.
I have the toughest job, I think, today because I have to introduce my boss. You know, in academia, we don't call each other bosses or whatever, but you know how that works. But I don't see an iPad up here, so I can't knock that over. But it's my pleasure to introduce Dr. Du Bois Bowman. He's the Dean of the School of Public Health here at the University of Michigan. He began his tenure as our dean a year ago. Almost a year ago to the day. It's pretty close to right exactly when you started. So I'm delighted to be introducing him. Dr. Bowman received his Bachelor of Science degree in mathematics from Morehouse College and his Master's of Science degree in biostatistics right here at the University of Michigan. And then he went to get his PhD at the University of North Carolina in Chapel Hill. His research focuses on the statistical analysis of brain imaging, mining data sets to understand mental and neurological disorders such as Parkinson's, Alzheimer's disease, depression, schizophrenia, and substance addiction. His research has helped reveal brain patterns that reflect disruption from psychiatric disease, detect biomarkers for neurological diseases, and determine more individualized therapeutic treatments. And so please welcome Dr. Bowman to the podium. I'm sorry? Oh, what are we doing?
Picture of them. Second.
Thank you, Mark, for the gracious introduction. And good morning to all of you. And thank you for joining us here at the University of Michigan. As I stand before you, I feel an overwhelming sense of urgency. And all of you work in the area of firearm death and injury, so I know that you share this sense of urgency. We see news about the topic seemingly everywhere in society, and for so long in the media and through other channels, the topic is presented or reflected as a political one. But I'm sensing a shift in society. I sense that people are starting to see and recognize this issue for what it is. And under any circumstance, from any perspective, it's a major public health crisis of our time. I'm optimistic that we're up to the task of addressing this problem. We have a history of solving difficult and complex problems as a society, but only when we have the courage to name them. I believe that a key to addressing complex public health issues lies in crossing lines. We must have the courage to cross lines and step outside the boundaries of politically safe discourse to say enough is enough. We must embrace the challenge to cross the lines of ideological differences, and far before we get to divergent ideology or political strife, there are things that all citizens can agree on and work toward to keep our children and our communities safer. We must be bold and cross the lines to name and openly discuss some underlying societal factors that place some communities at greater risks. We must cross lines of our academic disciplines and seek partnerships with community, government, and private sector stakeholders. I see examples of the power of such partnerships today in this room. 2 weeks ago, the Michigan School of Public Health hosted an interdisciplinary research workshop to start thinking about how faculty from across our 6 departments, together with faculty across campus, can cross disciplinary lines to deliver innovative solutions on the issue of gun safety. By way of analog, Dr. Cunningham mentioned at that workshop that 10 years ago, there were no more than 10 researchers on the University of Michigan campus who were focused on studying opioids. Today, there are more than 150 from different disciplines and areas of expertise. So similarly, it's critical that we pivot, use our relevant skills, methods, area of expertise to meet the demands of a complex issue like firearm safety. It'll take public health professionals from epidemiology to biostatistics, health behavior, health education, health policy. It requires going outside of public health and engaging our colleagues from other disciplines and other academic institutions and building strong ties, even outside of academia, to have the collective strength of community partners, law enforcement, emergency room doctors, engineers, social workers, legal scholars, policymakers, among others. We all have to get comfortable crossing lines, and I think FACTS is a wonderful model for doing so. I'm proud that the School of Public Health is part of this group in helping to lead on the issue. In a recent podcast that we do at the University of Michigan School of Public Health called Population Healthy, Dr. Cunningham uses the phrase, taking back the F word, to emphasize the need to start talking about firearms again. And as she just alluded to a few moments ago, on October 3rd, University of Michigan President Mark Schlissel did his part to take back the F word. During his annual leadership breakfast in front of university regents, deans, executive officers, media, external partners, he announced that the university would pursue a university-wide firearm injury prevention research initiative, which builds on the university's strengths and commitment to this area. The University of Michigan has secured more than $12.5 million in federal research funding just since 2017 to study firearm injury prevention. And the School of Public Health recently announced plans to house a $6 million multidisciplinary, multi-institutional center that'll provide schools with training and technical assistance to prevent school violence and serve as a national research and training center on school safety. These initiatives will help Michigan be a convener of experts and key stakeholders to collectively take back the F word and have a commitment to cross lines to affect positive change. So I'm honored that all of you are with us today to make progress on this critical issue. And I'd like to thank our keynote speaker, Dr. Deb Howery, Director of CDC's National Center for Injury Prevention and Control, and Dr. Valerie Mahomes, Chief of the Pediatric Trauma and Critical Illness Branch at the National Institute of Child Health and Human Development. She'll be sharing some details about the NIH portfolio on this issue. So I look forward to hearing more just about the outcomes, and thank you all for your commitment, again, to this critical public health issue.
Thank you so much, Dr. Bowman. And so now it is my great pleasure and honor to get to introduce Dr. Deb Howery. I've had the great privilege of working with Dr. Howery both in the field of emergency medicine and then throughout this journey through injury prevention science over the past decade, long time together. And I know it is complicated. And want to acknowledge that for her to join us here today, and yet appreciate tremendously her willingness to do that, and really acknowledging the shift that helps us really understand is ongoing. within our culture in the complicated times that we live in. And so with that, Dr. Howery is, for those who do not yet know, is the director of the CDC's National Center for Injury Prevention and Control. In this position, she oversees the nation's response to many critical public health issues, including the opioid overdose epidemic, suicide, adverse childhood experiences. Under Dr. Howery's leadership for the past 5 years, it has been, the CDC's work to prevent injury and violence has greatly expanded, and we deeply thank her for that. Since 2014, the CDC's violent death reporting system has expanded from 18 to all 50 states. The first ever national surveillance system on violent deaths collects data from law enforcement, medical examiners to provide comprehensive information on circumstances surrounding violent deaths. Data collected are used to tailor state-based violence prevention efforts. With Dr. Howery's support, the Injury Center produced the first CDC vital signs on suicide. The research also published in the CDC's M&M weekly report brought much needed awareness to this critical public health program and highlighted evidence-based prevention strategies. And with that, I think, everybody, all of us in this room would like everything to move a lot faster. I think we really have to acknowledge that we are moving. And with that, I welcome Dr. Howery to the stage.
Awesome, thank you. Well, good morning. Thank you so much for having me today. I'm glad to be here and have the opportunity to talk about the public health impact of firearms. As someone who's worked at a level 1 trauma center in Denver and Atlanta, this is a topic that is very important to me. I've seen firsthand the devastating toll it takes on victims, their families, and the entire community. I'm going to briefly cover today just some of the demographics around firearm injury and death, talk about some of the gaps we have in our existing data, really hone in on the National Violent Death Reporting System and talk about an example of how we've used it for child firearm injuries, and then just summarize some of the research priorities in the field. So it doesn't take much more than turning on the evening news to realize that gun violence is a serious problem in this country. While mass shootings are often covered extensively by the media, we know these events are only a small proportion of gun violence that occurs daily in our nation. Based on data from the National Vital Statistics System, there are over 109 firearm deaths a day and 3,300 deaths a month. In this bar chart, you can see the dramatic difference in the firearm-related death rate in the U.S. compared to that of other high-income countries. In this, you can see the overall firearm death rate was 11.4 times higher in the U.S. than in other high-income countries. 84% of all firearm deaths, 92% of women killed by guns, 97% of children aged 0 to 4, and 92% of kids aged 5 to 14 killed by guns were from the U.S. In this country, more than 39,000 people died from a gunshot wound in 2017, and a firearm is used in 1 out of every 2 suicides and 74% of homicides. This graphic depicts how 60% of deaths are related to suicide and 37% of firearm-related deaths are homicide. Drilling down a bit more and looking at intent, this line graph shows age-adjusted firearm injuries by intent. You can see the gradual increases in firearm suicides beginning in 2006 and the more recent uptick in firearm homicides since 2013. Rates of non-fatal injuries, which are higher than rates of firearm-related deaths, have been increasing over time. The majority of these are assault-related firearm injuries, followed by unintentional firearm injuries. Very few are self-harm due to the lethality of firearms when used in suicide attempts. Firearm violence affects people at all ages and all stages of life. Rates are much higher across the age span among males than females. Females are the light blue in this. And you can see here that homicide death rates are higher among younger people, ages 15 to 34, while suicide death rates are higher among middle-aged and older adults. The medical and work loss costs of firearm-related violence alone cost the U.S. about $64 billion each year. And this number does not include criminal justice or property costs, and it doesn't take into account the tremendous toll that firearm deaths take on families and communities. Now, just diving into some of the data and what are the gaps and opportunities. So we use the National Vital Statistics System to monitor and track trends in firearm-related deaths. Generally, there is a 1 to 2 year lag, though, before national and state data are available. Over the last decade, efforts have been ongoing to improve the timeliness of death data, and while all states are now using web-based systems for birth certificates, we have not made enough progress on the death certificate data. As of January, 46 of the 57 vital registration areas have an operating electronic system, although some of these systems are still not operating statewide, and many data providers are not using them to enter death data. We use, for non-fatal data, the National Electronic Injury Surveillance System, and this is for national data only, no state or local data. There's been challenges in the recent years with some of the stability of firearm injury estimates. There's also the HCUP National Emergency Department data, but this significantly underestimates assault-related injuries because of the reliance on ICD-10 coding versus narrative review of records when assigning intent. Eventually, we will be able to use NVDRS to monitor and track trends in deaths. We don't use this now, as some states don't have full state coverage, and not all states have data yet. The National Syndromic Surveillance Program, or ESSENCE, now offers a syndromic surveillance query for identifying suspected emergency department visits related to firearm injuries. This query can be used to complement efforts by states and jurisdictions to analyze these types of injuries and identify patterns. Since 1984, the Behavioral Risk Factor Surveillance System, or BRFIS, has collected data on health risk behaviors in all 50 states, the District of Columbia, and 3 U.S. territories. Each year, more than 400,000 adults are surveyed by phone, making it the largest continuously conducted health survey in the world. An optional module on firearm safety practices was available to states in 2017. In that year, 6 states administered that module. In addition, states have also added some of these questions to their state-specific questionnaires in 2018 and 19. Here's an example of how the BRFIS data was used at the state level. I think you all might know one of the authors. Earlier this year, an article was published in JAMA Pediatrics on firearm storage and adult alcohol misuse among households with children. These data were from Washington State, 2013 and 2016 BRFIS. Researchers found that there were an estimated 470,000 children in a household with firearms. Of these, almost 55% lived with at least one firearm not stored safely. Firearms were more likely to be stored unsafely in homes where an adult reported alcohol misuse. And we know there's an association between adult alcohol misuse and a child's risk for sustaining an injury. The Youth Risk Behavior Surveillance System was developed in 1990 to monitor health behaviors that contribute to the leading causes of death and injury among youth. Every other year, this survey is administered to public and private high school students in the U.S., and there's a number of questions related to weapon carrying, as well as suicidal thoughts and behaviors in interpersonal violence. And this is just a snapshot from the most recent data, which I think really provides insight into what is going on at high schools across our country. And finally, CDC's school-associated violent death study examines homicides and suicides that occur on the way to or from school, on school property, or at a school event. From July 1994 to June 2016, 423 school-associated homicide incidents occurred. From this, we show that 70% of school-associated homicides involved a firearm. When we broke this down into single victim versus multiple victim homicides, almost 63% of single victim homicides involved a firearm, and not surprisingly, almost 92% of multiple victim homicides included a firearm. And perpetrators who used firearms were often under the age of 18. Now I'm going to talk about CDC's flagship surveillance systems, the National Violent Death Reporting System, or NVDRS. So as Rebecca mentioned, when I became director of CDC's Injury Center 5 years ago, NVDRS was funded in 18 states. In the last year, we were able to expand NVDRS to all 50 states, Washington, D.C., and Puerto Rico. And this graphic shows the different years the states were added. We expect to have data from all 50 states in 2020. This is one of the Injury Center's most significant accomplishments, and I think will address some of the critical data gaps that I just mentioned. NVDRS is unique. It integrates data from multiple sources, including death certificates, coroner and medical examiner reports, and law enforcement reports. This really creates a detailed narrative that describes the circumstances surrounding the violent deaths and is a unique collaboration between public health and law enforcement. The value of NVDRS is in providing detailed information on the context and circumstances surrounding violent death. The system provides information on multi-victim events as well, including murder, suicides, and mass shootings. There are over 600 data elements captured, and just a few of them are on this screen. NVDRS does collect information on a variety of firearm-related data elements. However, the completeness of this information varies. Information is more complete for type, caliber, and make of firearm, and the data are far less complete for whether the firearm was stolen or how it was stored. We are working, though, with states to improve the completeness of these firearm-related variables. Now that I've given you an overview of NVDRS, I want to tell you a bit about a CDC paper we published in Pediatrics 2 years ago that I think really highlights how you can utilize these data. So previous research on childhood firearm injuries looked at selected outcomes such as deaths or injuries, or certain types of injuries like homicides or unintentional firearm injuries, and they were based on one setting. So my colleagues want to be more comprehensive and give a snapshot of this bigger picture issue. And as Rebecca mentioned, this is so important because firearms are the second leading cause of death among 1 to 17-year-olds and are just a major contributor to premature death, injury, and disability in children. We also know that secondary exposure to gun violence is a part of life for some children in the U.S. Recent survey results reported that 4% of kids were somewhere where they could see or hear gunshot bombs going off, or riots within the past year. And an article published by Charlie and colleagues from Columbia makes the case that youth exposure to firearm violence should be classified as an adverse childhood experience, or an ACE. And we know that ACEs increase the risk for lifelong physical and mental health problems. So the CDC study found that 19 people die a day or are injured by firearms, 3 deaths and 16 non-fatal injuries. Most deaths and injuries were due to homicide or assaults. You can also see that suicides make up a larger proportion of deaths than injuries because of the high lethality of firearms as a method of self-injury. Through the study period that went through 2014, firearm suicides went up and firearm homicide rates began to go down. So which children were most at risk? Compared with girls, boys had a 4.5 times higher firearm death rate. Compared with younger kids 0 to 12 years of age, older kids 13 through 17 had a 12 times higher firearm death rate. And compared with white children, black children had 10 times higher firearm homicide rates. The study found that for child firearm suicides, relationship and school problems, plus factors like a recent crisis, were just as important as mental health problems as a precipitating factor. Firearm homicides of younger children were more related to family violence, such as violence between parents, while firearm homicides of older children tended to involve more street crime-related violence. Most child unintentional firearm deaths involved playing with a gun. Sadly, 16% of younger kids actually thought the gun was a toy. Younger children were equally likely to be shot unintentionally by a peer or themselves, while for older kids, over 70% were shot by a peer. For both groups, when shot unintentionally by someone else, most of the time it was another child close to the victim's own age. And these are just the takeaways from the study. Again, child firearm suicides have really increased since 2007. Stressors are really important precipitating factors if we're focusing on prevention efforts. When you're looking at unintentional firearm injuries inflicted by other kids, are usually from the same peer group, and young kids are often caught in the crossfire of lethal domestic violence. So just summarizing some of the research priorities, which I know has really driven this conference. Healthy People 2020 has 2 national health objectives related to firearms. One is to reduce firearm-related deaths, and the other is to reduce non-fatal injuries. These same objectives are also included in Healthy People 2030. The CDC Foundation, in collaboration with CDC, called upon the National Academy of Medicine to identify the most pressing questions, including those with the greatest potential for public health impact and those that could be answered quickly. In addition, I've posted the facts research agenda as well. I think these really nicely outline some of the high-level questions to really fill those research gaps that are needed so we can focus our prevention efforts and reduce firearm injuries and death. So this slide shows examples of research priorities that are really needed to, again, fill this research gap, such as understanding the characteristics of fatal and really non-fatal firearm violence, where there are a lot of data needs. Patterns of access and use among kids, youth, and our military personnel, as well as really understanding both the effectiveness and cost-effectiveness of many policies that are currently in states or different intervention programs so that we can determine what's best and how to scale it up. So I think, as you can see from this room, there's currently a lot of momentum to improve our understanding of firearm violence and really build the evidence base. And I'd say almost every month now when I'm opening up a journal, I see many of your names in it, really building that evidence base for firearm violence research and just really focusing on how to prevent these injuries and deaths. I think today is really important, and I think Dr. Cunningham and Zimmerman and the whole FACTS consortium and many of you will continue to move this field forward, close the gap, and really help reduce the burden of injuries and deaths in kids and adults from firearms. So thank you very much for your time and attention. I look forward to connecting with you throughout the day and listening and hearing more about your work. So thank you.
Thank you to Dr. Howery. I have the pleasure of introducing our next speaker, who is Dr. Valerie Malholmes. Dr. Malholmes is the Chief of Pediatric Trauma and Critical Illness Branch at the Eunice Kennedy Shriver National Institute of Child Health and Human Development at the NIH. In her role as branch chief, she sets the vision and strategic priorities for research that address the continuum of psychosocial, behavioral, biological, and physiological influences that affect child health outcomes in trauma, injury, and acute care. I will also add that she's our project officer and that we appreciate all of her support as we have moved facts out. Please welcome Dr. Malholmes to the stage.
Good morning, everybody. Good morning. How's everything going? You awake? Good.
Lots of tooting.
And so got it. So I'm really delighted to be here, and thank you for inviting me to participate. And I'm really delighted to look out and to see familiar faces. And as I was commenting to someone earlier, I get lots of inquiries from the field, and I know all of your email addresses by heart. I have no idea who you are until you introduce yourself. So I'm just delighted to be here to put names and faces and email addresses and abstracts and specific aims together. Since my colleague talked in detail about the prevalence and incidence and the data around firearms and the research agenda, I'm going to talk more broadly about the funding picture, and maybe not so specifically about firearms, but the funding picture in general and the strategic plan that NICHD has recently put forward. Because, as your dean pointed out, we have to look at this and other compelling public health issues through the prism of multidisciplinarity. So this does not stand alone. The work that we're doing here does not sit in a silo on its own. But in order for us to make the kind of traction that Dr. Howery talked about and continue the work, for example, that colleagues at CDC are doing, we have to think about who we bring to the table, what are the other kinds of empirical questions that we need to address, and how we go about doing that. So I'm going to talk from the 30,000-foot level and bring in a little bit of a different perspective. And hopefully, if you haven't heard it before, you'll have some takeaways. And if you have heard it before, just smile nicely and nod. Okay, let's see. So I just want to point out, for those of you that may not be familiar with the NIH, this is what the NIH is, and this is what it stands for. And I want to underscore the mission of the NIH to facilitate and to move toward medical discovery and scientific leadership. So our job is not only to pursue these critical questions, but to build the next generation of researchers and to use the data, the evidence that Deb talked about to exact leadership in these areas so that we can wrap our arms around these seemingly intractable problems and to address them. So I want to take us back a little bit. The NIH hasn't always been the NIH that we know about, the 27 institutes and centers. In fact, when the NIH started, all the work was done primarily on campus. It was largely intramural. The work was done in a one-room laboratory on Staten Island and operated within the Marine Hospital Service, which was a predecessor to the U.S. Public Health Service. And the lab evolved into the Hygienic Laboratory, which moved to D.C., and with the Ransdell Act, became the National Institute, singular, of Health. And I just want to highlight this because embedded in the legislation is the importance of making this work available to the public and having public support for the funding of medical research. Here's a little bit of a walk in the past. You'll see the hygienic laboratory to your left. You'll see Dr. Ida Bengtstrom, the first woman to be hired as a bacteriologist in the lab. You'll see down at the bottom, President Roosevelt dedicating the new campus on the NIH. And there was a point at which the National Institute of Health became the National Institutes of Health and started building and adding institutes as time progressed. And you'll see Dr. Shannon, who was the director in the 60s, to receive a distinguished civilian award from President Lyndon B. Johnson. So we have a storied history, and as I mentioned, now the NIH comprises 27 institutes and centers, not only on the NIH campus, but abroad in the greater Maryland area, and there are labs all across the state and the country. We also have the National Institute of Environmental Health Sciences, which is in Durham, North Carolina. The clinical center, which sits on the campus, now is the largest hospital specifically devoted to clinical research. So I thought it was important to kind of connect these dots, to talk about scientific leadership, and to talk about the fact that this was an evolution of having just work done on the campus at the intramural level to moving it out to having public dollars, public access to research, and public support for medical research. Now, the founding of the NICHD happened in 1962 under the leadership of President John F. Kennedy. And what I love about what he said at that time really speaks to the role that the NICHD plays in funding the kind of research that you all conduct, but also looking at where there are synergies across multiple disciplines. So what he said is that we will look to the National Institute of Child Health and Human Development for a concentrated attack on the unsolved health problems of children and of mother-infant relationships. This legislation will encourage imaginative research into the complex processes of human development from conception to old age. And for the first time, we will have an institute to promote studies directed at the entire life process rather than towards specific diseases or illnesses. And I think that is really important, and we've tried over the years of our founding to have our mission speak to that. So we are one of the few NIH institutes that does not focus on a specific disease, but rather looks at how diseases and conditions affect children and families. I love this picture because you can see Eunice Kennedy Shriver giving her brother the pen to sign the legislation for the establishment of NICHD. And this is really important because, as you know, the Kennedy family had family members with intellectual and developmental disabilities, and they were really focused on solving and addressing some of these issues. In 2007, under the leadership of the late Senator Edward Kennedy, the institute was renamed the Eunice Kennedy Shriver, Eunice Kennedy Shriver being italicized, and we are required to italicize Eunice Kennedy Shriver, National Institute of Child Health and Human Development, focusing on her unwavering support of this institute and her work in this area. So I say all that to kind of bring us forward to today. The NICHD continues to support the research that it was founded to support, but more recently in 2012, late 2012, early 2013, under the leadership of our former director, Dr. Alan Guttmacher, our branch was formulated. NICHD had already been funding injury research and research on trauma and research on critical care, but it was diffuse. It was all throughout the scientific branches of the NICHD. And from advocacy by researchers and organizations like SAVOR, the leadership felt it was really important to have all of this research have a home and to be funded under the big tent of pediatric trauma and critical illness. So we are now supporting research. This is 6 years in for us that's looking to engender research in this area, to encourage research, I should say, stimulate research in this area to help reduce all forms of childhood injury, trauma, and critical illness. Now, those of you who know me know that when we were deciding on this vision, my goal was to eradicate it all. Just eradicate it, wipe it out. But they kind of pulled me back and said, let's start with reducing. So we changed the language here to reduce all forms of and aspects of childhood trauma. And that's our goal. And that's why our branch was founded. We have two big programs that constitute the work of our branch, and many of you have talked to the program officials in our branch. We have a critical care portfolio, and we have a trauma portfolio. Trauma portfolio has two distinctive programs, one that focuses on psychological and traumatic stress child maltreatment and violence, and another that focuses on injury prevention, emergency care, and trauma. And you can see some of the goals and priorities here of our trauma portfolio in particular. I'll just hone in on that. In that particular portfolio, you can see that since our founding, we have invested a significant amount of resources annually to build that portfolio, and that comes from the good work that you all have done. We fund about 80% of what we fund is through the investigator-initiated channel, meaning that we have had a few calls for application or requests for applications and specific program announcements, but you have been diligent in submitting your applications through the parent initiatives, and we have been funding meritorious science accordingly. You can see the funding mechanisms that dominate this particular portfolio. Not surprisingly, the RO3s, R21s, and RO1s are the mechanisms that are funded most frequently. But I also want to call your attention to some of the other initiatives that, other mechanisms that you might not be so familiar with, like the R24, which supports this research, the P50, which is a center grant initiative. We just launched that initiative to fund child maltreatment centers, and hopefully we will be spreading those across the country. The SC2 is a SCORE grant that NIGMS, the National Institute of General Medical Sciences, leads, and that we co-sponsored that research. And you can see the training grants. The R13 is a conference grant. The R25, which I would call your attention to, is an education grant. And there are several researchers who focus on, again, child abuse and neglect research who are leading and focusing on training in those areas. This is one way to look at the topics in our portfolio that are have been funded. Most of the peak is related to the child maltreatment research, but you can see where the gun violence research lies and violence research lies in that portfolio in terms of frequency. This is another way to look at it with the word cloud, and you can see child abuse and neglect research is clearly central in this. And I would say that we already had a robust child abuse and neglect portfolio. When I moved from our child development and behavior branch to establish the new pediatric trauma branch, some of those projects followed me to the new branch. So we already had a robust portfolio in that regard. But you can see where the injury and the emergency care research are really clustering around the center there, suggesting that this is one of the largest growing programs in our portfolio of research. And we're looking forward to having you continue to submit meritorious research on this topic. The R24 announcement was the first program announcement or funding opportunity that we put forward on the auspices of the new branch. And there was, this has had a number of lives, and you might recall that we have had a challenge in getting this out and having people understand what this mechanism is, why we were using it, and what the purpose of the R24 was and how it was different from the RO1. And one of the things that was really important to us is that we wanted to use a mechanism that would allow us to develop research resources that had utility beyond the work of the individual investigator, that would kind of build the evidentiary base, build the resources, build common language so that people could work together across disciplines to address and to answer these questions. So we funded Dr. Craig Newgard's work on the value of pediatric readiness in emergency care. Of course, Dr. Cunningham's work, which brings all of you here together. We funded Dr. Heather Keenan's work at the University of Utah, and she is looking at modules to manage medical stress, which certainly would be related very much to what you're doing. And Dr. Elizabeth Letourneau at Hopkins, who's looking at changing the paradigm and having us to have a common language as we understand child sexual abuse. So I'll just say very briefly that you can see that the funding for injury research has been relatively stable and continuing. to increase over the fiscal years. This is information from the NIH reporter. This is a public data set looking at all of our funding over the years, so you can search this on your own and find this information. But you can see all the injury categories. Some of these are overlapping so that this is not additive, but you can see the investments in this work. You also see the investments in violence research that we have supported, or that the NIH in general has supported across the NIH institutes, not just the NICHD. For the NICHD, this is a couple of years old, but the trend in funding remains about the same. You can see that we've supported child maltreatment research at about $10 million annually. The unintentional injury research at about $36 million, and the violence research at about $35 million. We've recently published a notice of special interest or scientific interest on emergency medical services to children. It's hot off the press, so I would encourage you to take a look at this to see how your work might fit within the priorities and the objectives for this new funding announcement. We're encouraging you to submit your applications. We're looking for RO1s, R21s, and RO3s on this topic. There is also a trans-NIH funding opportunity on dissemination and implementation. So some of the work that you're doing certainly might lend itself toward this. And I'll end with just saying a few words about the NIH strategic plan, or the NICHD strategic plan, which was just launched last month under the direction of our new NICHD director, Dr. Diana Bianchi. Our mission will remain the same, but the focus of the new strategic plan is on healthy pregnancies, healthy children, healthy and optimal lives. And you can still see within that mission statement improving the lives of children and adolescents and optimizing abilities for all. You can still see that thread of focus that was part of the original intent of founding the NICHD. So there are 5 themes. I'll call your attention to themes 4 and 5, improving child and adolescent health and advancing safe and effective therapeutics and devices, as areas where you might want to call attention to, pay attention to. And in fact, the scientific opportunities for injury research really lies within theme 4, where the crafters of this strategic plan laid out areas where exposure to trauma and violence would be relevant. And here's another area where the exposure to trauma and violence in theme 4 would be relevant. So I would encourage you, if you haven't already seen that plan, to take a look at the plan and to see where your work might fit. One of the other areas of that plan was on cross-cutting topics and themes. And so the goal is that every program, every announcement would have some relevance to one of these cross-cutting themes. So health disparities is one of these areas, and I would encourage you to think about gaps in health disparities in the work that you're doing. One of the things that we did in preparing for this strategic plan was to look at some of the highest risks areas and activities by race and ethnicity, and you can see that spinal cord injury by firearms is a disparity area for non-Hispanic blacks. Intimate partner violence is a disparity area in American Indian and Alaska Native populations, and you can see other disparity areas throughout. I just wanted to call your attention to those. And I would encourage you, as you're doing your work and thinking about the critical questions that you want to ask, to look at those areas where you might be focused on those cross-cutting themes. We often encourage, our goal, as I mentioned at the outset, is to fund not only the next generation of research, but the next generation of researchers. So we want you to be well poised to ask your questions, to submit applications, competitive applications, to do meritorious science. And we often have these regional training and sessions and workshops to help you ask and answer relevant questions. There's one coming up in Phoenix in November, and especially for you early career investigators, I would encourage you to do so. where you can learn about new policies that might be relevant to your work. So with that, I will stop and thank you for your time and attention, and thank you for the work that you're doing, and just encourage you to continue doing good work. Thank you.
Great, so thank you so much to our lead speakers here for your time this morning and energy. And, I have a few housekeeping items, and then we're going to move on to our day. But I just want to say, so some of the things that I hear from that talk this morning in my translation are, first of all, I have every intent, whether you like it or not, to try to rearrange your word cloud. So I'll just say that clearly. We'll work on that together as a group here. The other part is, I hope you're hearing really clearly that investigator-initiated science is being accepted. So we have a lot of posters here today. The work is often preliminary and really early and funded at these really low levels, and that's going to need next steps. And when you're getting to those next steps, you're going to think about some of these framings and pieces and ways to submit them. And the NIH is open for investigator-initiated science. And together, as we put those in, our peers will review those, and they will review them for science, and then they will move on. And that is the only way that we will continue to build the field. So with that, I'll move on to a couple of housekeeping items. First, I'd really like our FACTS Consortium funded members, we spent the day yesterday together, if they could just stand, because we've been working really hard together for the last 2 years, so that you can be recognized for the work that you've been doing to put this together. Thank you. I want to recognize that many of their time and efforts are completely not funded or vastly underfunded, and only through their daily passion and work and bringing in the others in their shop have we gotten this far together. So I want you to look today as we move forward through the day. There's posters up to go and have good conversations about those. I mentioned we have 48 abstracts from 12 states, including the District of Columbia and the United Kingdom. I was really delighted when we got science in to see that I didn't know many of the people who were doing the work, which really speaks to me, the way the field is expanding. We were also able to award some travel awards, because part of our work here as part of our R24 is really to build a pipeline and a capacity as well, and to encourage early career researchers and students. And so with that, we were able to fund some students to travel to today's conference. And I think if we do the old take on the saying, if you look to your right and you look to your left, I would say this is your field. And this field is going to be bigger in the future. And the students and the young people and the earlier career folks who are here, I encourage you really to talk to. You have some of the brightest minds in the field here today with a wide variety of perspectives. And this is a really amazing opportunity to interact. Some housekeeping items. If you have any questions, see our staff who are wearing our awesome FACTS t-shirts. We can talk about how you might get some of those later in the day. We do have a photographer taking some pictures. If you don't want your photo included, please stop at the registration desk and we can make sure that that happens. Bathrooms are located outside and to the left. There are also bathrooms on the floor below us. For those of you who are live streaming, we will take breaks during our poster session and during lunch, and those breaks will be about 40 minutes. And because of that, for the people in the room, we are going to try to stay on our schedule. It will be really difficult. We are really, really trying to encourage people to keep their name tags on to come in and out of the room. We purposely closed, as I said, the room in here itself, despite many requests that we had to not have media in the room itself, because I really wanted people to have a science conversation and just really among ourselves. And with that, I think one of the happiest things I heard yesterday, and even some this morning as we did some introductions, I'm starting to hear faculty stand up and say, young faculty stand up and say, when asked we have all multidisciplinary faculty working with us. We have criminal justice folks, we have public health folks, we have medical folks, we have really all across the spectrum. But I'm starting to hear people stand up and say, my field is I'm a firearm injury prevention researcher. And that just gave me just a tremendous amount of joy, because people didn't used to stand up and say that. And now we have that, and we have a whole bunch. And that is a field, and it's going to be a whole career for many of you. And so with that, I will kick off the day here and ask, let's see, did Dr. Carter leave us? Here we go, to come off and kick off our panel session. Did I have one more slide here I was supposed to do? Oh, I am supposed to say this. We are having questions for our panel speakers during the day. You have a number on your table, and they will get fed to our staff, and then that helps us keep our time for the day to not have to wait for people coming up to podiums and things. So if you have questions, text them to our chat, and we will then ask them, and you'll be able to get the panel to answer questions. Our keynote speakers are around for the day, for part of the day, and if you have questions, you can talk to them specifically.
All right, I just want to say thank you again to Drs. Bowman, Howery, and Malholmes for their talks. And with that, I'll invite our first set of speakers to the stage. Dr. Rahani, Dr. King, Dr. Heinze, Dr. Pizarro, and Mr. Arardi. And the first panel will be on preventing firearm violence among communities and schools, and will be led by Dr. Rahani, who is an associate professor at the University of Washington School of Public Health and Department of Pediatrics.
You know, while folks are sitting down, I want to say you might notice today that we very purposely have mixed our panels, as our consortium is also set up as a mixture of academic and non-academic voices. We really feel this is a really critical, important way for us to learn from each other and move ahead, and all of our panels today will generally have some mix of that. And so we invite you to enjoy those conversations. Didn't they stand up before? Oh, I think our stakeholders stood up before when we did the piece a minute ago, but maybe I could do that again. The stakeholders that we have in the room from our consortium, if they would stand, I would be most grateful. There's a handful. Yeah, in the back there. Yeah, thank you. Yeah. I've appreciated their outspoken thoughts on what we're doing right and what we're not doing right and how to think about this better. So there you go.
Thank you very much, Rebecca. Good morning, everyone. I'm delighted to be here to chair this session, the first session on preventing firearm violence in communities and schools. I want to thank Rebecca, Mark, Pat, Lainey, Lynn, and all your team. You've done a really marvelous job in getting all of us here together. So for those of you who are in the room and those who are watching us online, I think it's no secret that the entire communities in our nation are affected by firearm violence directly or indirectly. And in using the term violence, I'm referring to the broad typology of violence, including interpersonal, self-directed, and collective. So in the next hour, in this first session, you will hear about things like youth violence, suicide prevention, school shootings, mass shootings, and maybe throughout the day, those themes will also be repeated again. I think the statistics that Dr. Howery mentioned and showed were, they were so powerful that probably I don't have much to add. I would just say that, Justin is going to talk to you about issues of school shootings, but to just give you some numbers, based on some estimates, more than 200,000 students have been affected by school shootings since Columbine. While definitional challenges exist about, what really is a school shooting or what is really a mass shooting, the reality is that no matter how you look at it, the number of children who have been injured or killed during school shootings, for example, is really, really a high number, around 400 or 500 students since Columbine. And that is just incidents in which there was at least one injury. The number of threats and carrying guns to schools, all of that is really probably much more, and their impact is not well understood. So we are going to have 4 fantastic speakers today. Dr. Cheryl King from the University of Michigan, who will talk about firearm safety strategy for rural communities. Dr. Yesenia Pizarro from Arizona State University, criminology and criminal justice, who will talk about busy streets using diminishing physical and social disorder as a tool for firearm violence prevention. Dr. Justin Heinze of University of Michigan will talk to you about some of the really exciting multi-level work that they are doing in terms of school climate interventions. And then lastly, you will hear from Dr. Joe Errati, who I'm really, really happy and pleased to be in this panel as one of our stakeholders, who has been a school superintendent for about more than 2 decades. And he will talk to you about some of the lessons we have learned since the Sandy Hook tragedy. Each of us will talk about 10 minutes. We will not take questions immediately after each talk, so the people will present back to back. And then as Dr. Cunningham mentioned, toward the very end, we have built about 10, 15 minutes for all the questions that you have. So let me use my rest of my time, maybe the remaining 5 minutes or 6 minutes, to share with you, in keeping with the theme of the first session, which is firearm violence prevention in communities and schools, some of the work that we are currently doing at the University of Washington. And as Rebecca has mentioned multiple times during these meetings, the field of firearm injury prevention that we are building is really exciting. Part of that is that some of even the ABCs or foundational knowledge in this area is very much limited. So one of those areas is rural health. And the reality is that if you focus your research on just large urban areas in the United States, you are leaving out as much as you have covered, because that's only about 50% of the US population. So what about other parts of the nation? So the work that I'm presenting today is funded by NIAAA, NIDA, NIMH, and NICHD as part of the work that our colleagues at the University of Washington School of Social Work have been done through the umbrella of communities that care. So this is really their work that they have been doing, and we've been collaborating recently to look at some of the firearm data elements that they have. I'm going to present just very narrow portion of the work that's being done, which is descriptive. The analytic work and inferential work is underway. But before I get there, I want to mention, many of you probably are aware that a couple of months ago in the Journal of Behavioral Medicine, a series of papers came out, including some of the scoping reviews that FACTS Consortium had put together. And one of those scoping reviews was this one that you see on this slide, where a team of investigators worked together and did a really comprehensive review of the literature on firearm carrying among youth. And they said in that relatively long paper, there are 2 sentences I want to highlight here, that there was only one study that explicitly measured rural carrying of guns, and no studies characterized firearm carrying among rural youth. So to fill that gap, at least partially, and this is the only study that they mentioned. This is a study in Texas 20 years ago. It was a study of 8th graders and 10th graders, and it was a question about handgun carrying to school. So in order to partially, at least descriptively address that, we use data from the Community Youth Development Study, which is a community randomized trial of 24 different rural towns in 7 different states: Washington, Oregon, Utah, Colorado, Illinois, Kansas, and Maine. And it turns out that they had a couple of firearm-related questions in that survey. One of them was, how many times in the past year have you carried a handgun? And these are rural areas. And of course, this has limitations. It doesn't have the context. It doesn't say where they carried. It doesn't say what they were doing, but at least provides some information about the magnitude of this behavior among rural youth. So just some slides for you. These are 6th graders and 7th, and then through age 19. And as you can see, separated by sex, boys and girls, or female and male, you see the numbers that through age 19, about 1 in 3 boys and about 1 in 10 girls had carried a handgun. And the majority of them actually stayed in the rural settings through their adolescence. Looking at it another way, cross-sectionally at each point, you can see about the numbers, they were stable. And part of that is, this is an episodic behavior. So, 10 or 11% of boys at each cross-section, they reported carrying a handgun in the past year, and about 2 or 3% of girls. Good. And then among those who had ever reported carrying, and this is the bottom panel here, you can see about a notable proportion of them had already carried a handgun at grade 6. So those are some notable findings in terms of when we think about some of the strategies for intervention. In terms of the number of assessments at which they actually reported handgun carrying, most of them reported only once. So it was just one assessment during which they said, and this is in keeping with our understanding of the epidemiology of firearm carrying during youth. It's mainly an episodic behavior. There are teens who do carry continuously and persistently, but it's very episodic. And here, in terms of the number of times they have carried again, it's about 1 or 2 times. Most of them, there are obviously those who carried a lot, and this is not uncommon in research that we do, that there are those who report carrying a lot, but the majority were only 1 or 2 times. So I'll just wrap up here by saying that in this study using longitudinal data over several years, you can get a sense of the frequency of handgun carrying. And it's important to really talk about the type of gun, because obviously there are differences between handgun and long gun in the context of rural settings. So 1 in 3 males and 1 in 10 females had reported carrying a handgun, and many of them actually had already done so at grade 6. And I think this is just the building block or the first step to actually do ideologic and inferential work to look at antecedents of this behavior and consequences of this behavior, which is the work that we are doing. So speaking of rural health, I'm going to ask Dr. Cheryl King to come to the podium and start our session on some really exciting work that they are doing in rural areas.
Just do it here.
Lynn, do we have the... It's yours.
Yep,
Yeah,
that's
I think we're good. Perfect. Go ahead. Thanks.
Good morning. This is the right sequence. So thanks to our panel chair for setting it up this way. So we've heard a lot of really rich information already this morning about firearm statistics, research programs and priorities, the NIH research funding opportunities, and we're definitely going to go down now even more into the trees and talk about one particular project, which is an initiative to develop a firearm safety education program for rural communities. And I'm just going to, these are short. I'm going to take this opportunity to tell you about just one slice of this developing project. And it's the first slice, and I think our team would say probably the most important slice. And that is to be sure that going forward, the research that we do is tailored to the community that we're working in, that we've heard voices from the community, and that the way we approach the research and the questions we ask and the data we collect will all be meaningful to this community as we move forward and actually develop a firearm safety education program. So the objective here is to develop and pilot it. This is a one-year project that we hope will continue into a longer-term program of research, with larger scale studies. But what we're trying to do is figure out what is the most appropriate for our community message. What type of firearm safety message? What are the components, the content of the education we want to deliver? Who are the most appropriate messengers in the rural communities to deliver the message? And what is the messaging strategy? Is this watching YouTubes? Is it doing a decision aid? Is it handing out information sheets? Is it public lectures at school, or some combination of the above? We're doing this work in the Upper Peninsula of Michigan. As you probably know, Michigan is surrounded by Great Lakes. The Upper Peninsula is really upper. One of our community members of the team made the drive down yesterday, and I think it was the day of the drive. It is quite a distance away and extremely rural on the whole. So it's nearly a third of the land of Michigan and a very small percent of the population. And just to give you an idea of community partners, and I know this is a small font list, so the particulars aren't important so much as to share that we have a really broad representation from the community, from the police, to state trooper community members, to mental health, to the schools. And these are not the people we'll be doing the focus groups with, but our community partners to figure out what questions to ask in the focus groups, to figure out what resources to share with the focus groups to get their input on, and even who and all should we be sure to include. And what are we going to be doing in terms of things we want to be sure we do get from our community partners before we go forward? Well, one is when we approach working in our focus groups, what questions are even reasonable to ask? We don't want to offend. We want to gain a lot of information. What has already been tried in the community? What do you think would be helpful? What do you currently teach your children about firearm safety? How does your community think about firearm safety? What have been the barriers to firearm safety in your community? So really learning, for instance, not to ask in the focus groups, how many firearms do you own? And so that's one of the messages we learned. Don't begin a focus group and ask everyone in the group to share how many firearms they own and the types of firearms. It's really just figuring out how to approach this. In terms of focus group probes and participants, have we included them all? And we talked about including one for people who may be veterans, police, people who are working in the sheriff's department. There may be one for people who are teaching firearm safety, who are selling firearms, people from schools. We definitely want to hear from families. And then looking at those materials, we can only show so many in a focus group. There are a lot of existing materials to kind of figure out which are the ones to go forward with. And I just want to share just a few things just to give you a sampling of some of what we've learned so far. I mentioned they definitely tailored our focus group questions. We went in with a draft of what these would be, and we received some really good input on how to revise these questions and approach it differently, more from a values perspective. What to ask and not ask, I mentioned who to ask. They have recommended that we go a bit younger. We were planning a middle school and a high school focus group. Now we're also, on their recommendation, considering an upper elementary school focus group to learn what children say they are learning in their families and how their families approach it. One can get a hunting license in Michigan beginning at the age of 10. You can also hunt with a gun at the ages 8 and 9 with a parent and someone who has a license. So really, beginning in middle school is late in a hunting community. Some of the materials, and I think this is one that really struck us. You may be familiar with this one. I believe this is from the American Academy of Pediatrics firearm safety handout. There was a fairly rapid response to this informational bit, and it was not positive. And I pulled out the one on the top left is what they liked best. The one on the top least, they disliked. And the one on the bottom left, they actually did like. But the top left, how did they see that? Now, if you think of it from this community perspective, you can probably guess. You're telling me I'm not as good a parent as someone else if I have a firearm in my home. And there are firearms in most homes in these, not all, but many homes in these communities. So to put it out there that the safest home for children and teens is one without guns was very off-putting. Did not see that as being useful, as wanting to look further at this handout. However, the one on the bottom left, which is factual, relates more to safety, was fine. People thought that was useful and would be helpful for people in their community to see. So, it's many different kinds of information we put in front of them. We receive this kind of rich information. Here's one that is from our Injury Prevention Center. What they really liked here on this page of this, I think the first page was more statistics. Statistics were seen as fine, but not so many. But what did they really like? Practical information. This was very positively received. That you're not just telling me what bad is going to happen, what I'm not doing right as a parent. You're telling me what I can do to keep my child safer, and a very strong value on firearm safety in the communities we were in. A lot of pride about a firearm education and safety. And here, and I understand now, people are beginning to question, and we need to learn more, what really is safe firearm storage. But the idea that they're given a website and information was viewed very positively. This is one that some people were familiar with. This is the National Shooting Sports Foundation or Federation. And this is actually a several-page magazine. And although it's a lot of information, people saw it as really very good information. And it has ideas about safe storage, very positive. The other thing I can say about this National Shooting Sports Foundation is their website. They have a partnership now with the American Foundation for Suicide Prevention. They have a video about firearm safety approaches on their website, and they have additional materials about firearms and suicide prevention. So again, this was seen as more culturally tailored than some of the other materials. And then an idea that came from our community partners is that we needed perhaps to focus less on developing new materials coming out of our universities and institutes, and more on putting the firearm safety messages into the materials they access regularly in their community. And this was an example that someone who was so invested in this topic, he attended all 3 of our community meetings that were in different towns. At the 3rd meeting, he brought this forward and really found his voice to share the recommendation that we look at things that are currently being distributed widely, such as this, when people get their hunting license, and there's other examples too, and work on getting our message into these materials. I just wanted to put the names up of all these folks who gave us a great deal of input, and of course, thanks to my co-lead, Cindy Ewell-Foster, Sarah Derwin, who is our person making it happen in the Upper Peninsula and was able to join us today, and all of the other faculty team members. Thank you very much.
Justin's? Yeah. Okay, sure. So, thank you very much, Cheryl, for that really great presentation. So the next speaker is going to be Dr. Justin Heinze of University of Michigan School of Public Health, and Justin will talk about some really exciting, multifaceted, multi-level work that they are doing in schools.
The on button. This clicker's probably a bad idea anyways because I'm going to wander. If I start to drift and you can't hear me, just somebody kind of point this way and I'll make my way back to the microphone. I was listening to the statistics this morning, and I anticipated hearing those statistics, and they're very sobering. And it often draws my attention away to the injury and mortality that is related to firearms, and that's incredibly important. But I also feel it can sometimes force us to overlook the subtler ways that firearm violence can affect some health disparities. And as an educator, I'm an educational psychologist by training.
Justin, for the live stream, I want you to listen to the microphone.
All right. I'll just put this clicker down, so now I'll definitely stay here. As an educational psychologist, I'm interested in the learning environment. I want to know, how do schools affect long-term health disparities? And so when we think about your vision of a school, what kind of learning environments are we creating for our students, our young learners? Do they look like this? Big windows, collaboration, transfer of knowledge, or are they starting to look more and more like this, where the threat and security that's related to violence, that's related to firearms, are salient enough where they're changing some of the outcomes and expectations for our students? And I've had an opportunity to speak to stakeholders all throughout the country, and the things that I hear from them, this one in particular, this is about 8 miles away from Sandy Hook Elementary. Look at the quote. Since the shooting, we've been learning how to hide. You don't see reading, writing, and arithmetic here. You see a preoccupation with safety. And how does that influence our learners? How are we drawing attention away from academics that might in turn create disparities down the line? And for a long time, when I thought about safety as from a broader perspective, I took the firearms out of the equation because, yes, firearms are a huge issue, but oftentimes when we think about the many different ways that people can get injured or hurt within schools, we need to think about what happens on a daily basis, the microaggressions that are happening, the emotional and psychological violence that might be happening, the bullying and intimidation. And for those of you who sat through Psychology 100, you probably recognize Maslow's hierarchy. You need to have these basic foundational pieces in place before you can self-actualize yourself as a learner. You need to have the physiological needs met, you need to have feelings of safety, and you need to feel like you belong. Again, before you can move up and really create a learning environment that's going to help everyone reach their full potential. And this pans out in the literature. I don't have the citations up here, but essentially you see some of these basic safety and belonging needs manifesting themselves through negative outcomes. How does connectedness play out in terms of internalizing behavior? The connections that we see between peers and teachers are associated with deviant behavior, ostracism, school climate in general, and how that milieu that we're creating for students can affect all of these outcomes that, again, lead to disparities. And for that reason, I often decoupled the kind of work that I do in promoting school safety away from firearms. But the more and more I learn about this field, and the more I'm engaging with stakeholders and other researchers, is all of these things can be antecedents. They can be precursors to the event where a firearm is present. You might not see firearms up on this slide yet, but down the road, each of these pieces can play a part in promoting or potentially preventing firearm violence. And so I've been excited to work with the Sandy Hook Promise Foundation over the last about 4 years to test their suite of programs that are designed to look at more upstream predictors of firearm violence. So they have 2 key programs. One is Start with Hello. The principle is pretty straightforward. You're trying to promote connectedness. You're trying to promote student engagement. It sounds easy in theory to walk into a hallway to say hello, to sit down at a table and invite someone who might seem like they're alone to be part of the conversation. It's easy to do now when we're adults, maybe. It's not so easy to do when you're a middle school student. It's not so natural to do as an elementary school student. So they've created a curriculum. They've created paraphernalia. They've created promise clubs where people can engage in activities that are designed to create that inclusivity. What a wonderful idea to make the environment a more welcoming place. And maybe that starts to diminish some of the ostracism and some of the loneliness that you might see within your school environments. Say Something is the second piece of their suite of programmings. It's a fairly familiar refrain. If you were at Detroit Metro Airport this morning or yesterday, you hear this message being shouted out over the loudspeakers. If you see something, say something. We often believe there's this innate ability in each one of us to recognize someone who might be suffering, to recognize someone who might be in crisis, to recognize if someone might be a danger to themselves or others. This program is designed to teach this explicitly to the students at schools, to the teachers at schools, to parents as well. Because oftentimes, in retrospect, when someone has committed self-inflicted violence or they've committed an act of violence at schools, people will talk about, we saw those signs. We recognized those warning symptoms. It was either through social media. It was through their schoolwork. It was because we just thought they were a teenager and acting moody. Who knows what that might be? But can we explicitly, again, teach these messages so that students then can recognize that someone might be suffering? Second, importantly, that they have the self-efficacy and confidence to reach out. Again, it's not something that's natural to us. We think someone might be suffering. Are we brave enough to stand up and tell a teacher, tell a trusted adult that person might be suffering, understanding that there could be consequences for you or for that individual as well, and then ultimately creating those avenues. Again, easy in theory to think about, I can say something, but do I have a trusted adult with whom I could converse about these things? Is there a platform for me to report this information? All right, and so it's the combination of these two programs that we believe might manifest in a long-term, a reduction of some of these long-term harms. So what we believe is if you implement these programs with fidelity, you might see some initial changes in just some of these basic first steps. And this is based on models from public health, like a health belief model. If we talk to Cheryl, you'll see these initial behavioral change models. You don't go from presenting information to behavioral change like that. It's not like switching on a light switch. It's more like turning an oil tanker. It takes a little bit of time, and you have to have some of these preliminary steps. Where you build in some of that self-efficacy, some of those avenues to report. We believe by doing that, you're not only going to start to see a change in the climate of these schools, where people are encouraged to be inclusive, where people are encouraged to reach out and help those individuals that might be a risk to themselves or others, but then also have an influence on some of those long-term outcomes. Now, I feel that there is an energy and excitement about this field moving forward and moving quickly. I'm focusing, and my colleagues are focusing, we have a few of them in the room, Mary, Mark, Andy. We want to take time and develop an evidence base to make sure that what seems obvious, I present the information, you now have the knowledge and ability to report. I want to make sure that that piece is solid first before we ever start to attribute some of these later pieces back to our behavioral change. And so a lot of the work that we've been doing is trying to make these foundational connections, because there are so many programs that are existing in schools now that don't have a lot of evidence to suggest their efficacy. So is it a good idea to promote inclusivity? Is it a good idea to tout the message, see something, say something? It was at the Metro in Chicago, it's at Detroit Metro Airport. Does it make sense to include in schools? I don't see a lot of evidence out there to say that one way or another that this is the path that we should be following. And this is too important of an issue for parents, for students, for all those that are engaged within the broader stakeholder perspective to not make sure that this foundational piece works first. And so we have a couple of pilot studies, and again, we're trying to build that evidence base. So starting in 2017, this was kind of a non-equivalent control group design. We had about 20 schools in Los Angeles County, Los Angeles Intermediate or Unified School District, as well as a couple charter schools. This was a convenient sample. We were looking for schools to participate. We had middle schools, we had high schools, and we were just going to do a basic kind of pre-test, post-test to see whether or not we started to see some initial changes in some of these outcomes. We really wanted to look at some of the implementation and fidelity of the programming itself, and then see kind of where we're starting. We learned a lot from this study that kind of informed our next pilot study, where we're pushing up the rigor. Now we're trying to introduce a randomized controlled trial. We are still following the same kind of pre-test, post-test model. We learned from the initial pilot study that inclusivity message, that start with hello message, got lost a little bit with our high schoolers. It was the middle schoolers that seemed to really internalize that message and want to think about it. So we now are focusing on what we believe is the population most of interest, most primed for these interventions. And then we're also integrating some administrative data and archival data. So from that very first one, we see that first piece, that very first step might be happening. You implement the program, and there was some variability in the fidelity with which the program was implemented at every school. I mean, this is kind of a cluster design, so there's always going to be a little bit of variation there. But this important caveat is that this really worked for those that were exposed to the program, and this informs this next study and our future studies moving forward. The program exposure is designed as a universal strategy. This is not targeted or indicated strategies. These are universal strategies that are supposed to filter down. But it did make a big difference if they were really actively engaged with the programming. Now we introduce the RCT. All pilots have their own little flubs here and there. This one just happened to be co-occurring with a teacher strike in LA. So I had to, I don't know how much a teacher strike, so for my 622, my evaluation students in the room, this could be a threat to the internal validity. But that did happen. But we, even with that strike, even with some of the caveats that I would have to introduce and be happy to talk to folks about, we still saw those first steps. That self-efficacy to report, that knowledge about reporting signs, it seems to be coming up. All right? We are going to spend a lot more time thinking about what engagement and what kind of that dose received idea means. And so in this second pilot study, we collected a lot about how much they interacted with the program, how much did they engage with the program. So really kind of driving deep into what it means to experience this program, and then can we attribute sort of these the behavioral outcomes to that engagement. So do we see some of that same kind of program engagement interaction effect? And again, I'm happy to talk with anybody about some of the results in more depth. Now move to yet another body of evidence that we hope to create over the next 3 years. This is funded by the National Collaborative for Gun Violence Research. We have 21 of 24 schools on board. Again, in LA, we are going to randomly assign 12 schools to each condition. And now we want to see if we can sustain that effect. Can we see a sustainment of those initial changes, one, over the course of the study period, but then can we also start to see some of the behavioral change? So my time is up, but I will be happy to answer any questions after. There we go. All right.
Sure. Thank you very much, Justin. So as Rebecca has mentioned, one of the main powers of the FACTS Consortium is to bring people from different disciplines together. So we have epidemiologists, psychologists, psychiatrists, and people with education, doctoral education in education as a discipline. Next, you're going to hear from a criminologist, Dr. Yesenia Pizarro from Arizona State University. We'll be talking about some exciting work in physical and social disorder.
Thank you, and good morning, everyone. I have to say that as a criminologist, I'm very excited to be here, and I'm very excited to be learning from all of your work and also building bridges. And because we all have the common goal, right? Save lives, create safer communities. And what better way to do that than all working together and playing to our strengths. So today, I'm going to be presenting preliminary results from one of the FACTS-funded pilot projects, the Busy Streets Project. And Busy Streets is rooted on crime prevention through environmental design. Crime prevention through environmental design posits that you can have a positive effect on crime, a reduction in crime, by manipulating the environment. And there are many ways that you can manipulate this environment. Things like increasing lighting, trimming landscape. Those are all types of crime prevention through environmental design. But what we're focusing here is on greening, which is a form of crime prevention through environmental design. And greening refers to the beautification and maintenance of blighted properties. And this could take many forms. It could take mowing, the form of mowing. It could take the form of cleaning the debris, creating community gardens, and planting vegetation. Theoretically, when we look at this, and I'm looking at this mostly from a criminological point of view, the whole notion that this might work is based on the idea that you're fixing broken windows and that in doing so, you're increasing collective efficacy and social capital within the community. And by fixing broken windows, we're referring to this whole idea that if you fix smaller problems within a community, you're going to prevent bigger ones from occurring. And the reason that this would occur is because you're sending out the message to would-be offenders that this is not a welcoming place for you. The community cares about the environments, and if you come in here and you act up, then somebody's going to do something about it. You're not going to get away with it. Collective efficacy is very related to this, and this whole idea of building social capital and the willingness of residents to come together in the community to solve community problems. So it's a sign that you fix those broken windows. But in essence, what that also creates is busy streets. And by busy streets, I'm referring to this whole idea of creating more traffic within the community. And why would creating more traffic and more foot traffic and more people being out and about is important? Well, it increases guardianship. Again, if you're thinking of your average rational offender, if there's more guardianship, they're not going to go in to offend in these places because of the odds of getting caught and getting apprehended. Now, there's been a lot of work recently in the area of greening, and I admittedly forgot to put my references here, but I know that a lot of this work have been conducted by people who are sitting in this room, so I do acknowledge you. And but what the work here has told us is that greening as a whole serves to decrease overall crime, specific types of crime. We know that greening is also related to perceptions of crime and reductions in fear of crime, but that it also increases collective efficacy and social capital within communities. And we build on this work by examining the effect that greening has on crime within our work. So our work was conducted in Flint, and we did a quasi-experiment where we looked at 3 different treatments. Well, 2 actual treatments and a no treatment. We had community engaged screening, which refers to instances where community members self-initiated and came together to mow and beautify vacant lots within the city of Flint. It is important to note that these efforts have been underway, the community greening in itself have been underway in Flint for years before we started. Then we have the professional mowers, and that is, in those treatments areas which were randomly assigned, we actually paid a professional mowing company to come in and do the treatment of mowing and beautifying. And then we had the no mow, where nothing occurred. Really quickly, we hypothesized that the greening treatments was going to have a crime reduction effect in the treatment, in the areas that received treatments, and we also hypothesized that the community engaged greening treatment was going to be more robust. It was going to have more robust effect. Our main outcome was firearm crime incidents, and we did some fancy modeling. So if fancy modeling questions come, I'm going to point it to the person that did the fancy modeling in this table. So although our main variable of interest was firearm crime, we did do some analysis on overall crime. And what we find here, in a nutshell, is that the treatment effect did serve to suppress the seasonal peaks that we were expecting during the late spring to early fall months. So if you see 2015, you see that they were high. During that same time in 2016, you see a reduction. The pattern is pretty similar when we actually looked at firearm offenses. It might not look as pronounced because we had a smaller number of cases within the area. Of course, a model cannot be missing, so we modeled it. And in essence, what this model tells us is that prior to the treatment, both the community engaged and the professional mow areas had higher crime rates than the treatment, than the control area, and that there was higher neighborhood disadvantage. Interestingly, contrary to our hypothesis, we found that it did have, if you look at the interaction effect, we did find a decrease, but only a statistical significant decrease with the professional mowing. And we think that the reason for this is that community engaged mowing group have been working in Flint for years prior to our intervention. So there was some contamination going on. And that's just a fancy figure that shows the Model 3, if you want to see how the direction of the findings. In summary, what we found was that greening is in fact associated with the suppression of seasonal firearm crime spikes, as we expected. However, our second hypothesis was not supported, as we did not find that community engaged groups had a statistically significant difference. Although there was a reduction, but it almost made statistical significance. If it counts, it was almost statistically significant. It just didn't. It was 0.057. We only needed to go to 0.05. We would have talked about it. But we believe it's the contamination issue. Implications. As a criminologist, I am very excited about these implications because I generally study arresting people, right? So you're going to arrest people, you're going to incarcerate them, you're going to put them through the system. And the big takeaway for me as a criminologist is that we could actually do things that don't involve sending people to prison, which has problems in and of itself. So, and it's more cost effective than putting someone through the criminal justice system. So this is something that's definitely worth exploring. And as I mentioned, these are preliminary results. We're still working on getting more data and analyzing the data differently, particularly looking at mowing intensity and looking at trends more longitudinally. And that's all I have. I made it through my time.
Thank you so much, Jesse. So last but not least, Dr. Joe Erodi, who I'm really pleased to introduce to you. As you know, I mean, probably you experienced Sandy Hook, changed many people's lives, probably your life as well. And Joe is going to talk about some of the lessons learned since Sandy Hook from his perspective as a superintendent for the past 20 more plus years.
Folks, good morning, and thank you first for the opportunity to be here as a stakeholder. It's an incredible privilege. What I'm hoping that my few minutes in front of you will bring to your attention is how important the research that's happening needs to get to the field of public school leaders. Time is treasure. And what I want to do is take your data points, and I want to try to put faces in front of those data points for you, and for you to recognize how important your work is and how the need to move forward is just, it needs to happen yesterday.
Just after 9:30 this morning, Newtown Police received a 911 call for an emergency at the elementary school. Newtown PD, upon obtaining information as to the stature of the situation, contacted the Connecticut State Police and requested assistance from state police and surrounding local police departments. On and off duty troopers responded to the school, and with Newtown Police, immediately upon arrival, entered the school and began a complete active shooter search of the building. That included checking every door, every crack, every crevice, every portion of that school. Our main objective was to evacuate as quickly and efficiently as possible any and all students and faculty in the school. The entire school was searched. That was accomplished. The staging area was set up. Students and staff were put into that staging area, and soon thereafter, the children and staff were reunited with their parents and their loved ones. There were several fatalities at the scene, both students and staff. There is no information relative to that that is being released at this time until we've made complete proper notification. The shooter is deceased inside the building. There's a great deal of work that is undertaken immediately upon locating the shooter, and that is there's a great deal of search warrant activity, there's a great deal of law enforcement activity both in and out of state to ensure that we cover all the bases relative to that specific individual. Suffice it to say the scene is secure. State Police Major Crime Squad, Newtown Police Department, Danbury State's Attorney, and many agencies are working together to answer all the questions surrounding exactly what happened.
I apologize for that volume, but boy, do I have your attention, don't I? This was the piece that played to Connecticut school leaders at that moment in 12/14/12, now nearly 7 years ago. I was a school superintendent about 20 miles and 20 minutes from Newtown Public. I was a point in my career where I was looking for one additional challenge, and I had opportunities to go lots of different places and spaces, and I raised my hand, and I'm so glad that I did, and I was chosen to be the superintendent for Newtown Public Schools. I arrived in Newtown about 9 months after the tragedy. I want to share with you a couple of situations that presented to me immediately. The first meeting in Newtown, prior to my actual start date, I was called by a dad. And the dad opened the conversation with, "Doc, I know you're our new superintendent. I don't know anything about you. We'd like to have you over the house. And with your visit, there'll be a number of impacted families." My first visit, as I entered the living room, had 17 families represented, all with one common denominator, that they had lost their son or daughter. My commitment to Newtown Public and my further commitment to this country, which I think that offers such great education through our public schools, is that we have to get better. We have to get better at school safety. Upon my stay in Newtown, every morning started at 6:30 a.m. with an open hour for the community. Newtown Public Schools, incredibly complex, but the reward that I had from serving as their superintendent was the highlight clearly of my career. I had the privilege of reopening the new Sandy Hook Elementary School. I had the privilege of watching a community that was taken to its knees begin to feel okay about itself. But the lessons learned from Newtown Public, I think, are lessons that this country has yet to pay full attention to. My present work as a consultant for the National Organization of American School Administrators is I go across the country and I share lessons learned and I share best practice in regards to situations that still need to be corrected. And the sad part about the work that I do is that everybody wants to talk about evidence-based, and yet no one has the cadre of evidence behind their belief. I speak to urban school superintendents and public school safety leaders, and they are so endorsing that every school needs to have something which students have to walk through to be searched for weapons, yet there's no evidence. I speak to administrators across the country on their school safety plan, and I share with them that the best safety plan is a plan that's never complete, and they don't understand that. I think what I'm, if I can move my next slide, I don't know if I can. What I believe, and the reason why I so quickly raised my hand to be a part of this work, is that what's happening with research scientists, particularly around gun control, is a linchpin of information that school leaders have yet to understand, have yet to be privileged to, have yet to respond to. So what we continue to do is what we believe is best for students from the belly, from the barrel of our belly. And I'm not certain that's the best approach when it comes to school safety and school security. What I'm absolutely certain is that what we've experienced across this country, they are not random acts. Adam Lanza was not a random act. Adam Lanza was an avoidable, horrific crisis in a community of a high wealth community, in a community that had great partnership to its public schools. How do you allow a postgraduate of their high school to live in the basement of his home with black garbage bags over the window, so no light. Anorexic, 6'1", 110 pounds. His only link was his mom. His mom was still alive. She should be incarcerated. Adam Lanza brought to Sandy Hook Elementary School a 12-gauge shotgun. He brought a Bushmaster automatic, semi-automatic, a Glock 10 millimeter handgun, and a 9 millimeter semi-automatic. And he brought enough ammunition to take out the entire school. He left behind in his home more weapons than he brought with him. How does that happen? I think it's really important that school administrators understand one essential question. And boy, I'm hoping research scientists can help us out. And the question really is this: how as a community, as a school community, and as a community, how as a community do we know our most complex student, our most complex parent and staff member, and our most complex community member? That's the question. And how does that play into gun safety? What we have learned since Columbine, through Sandy Hook, through Parkland, and a whole bunch of other tragedies in between those three, is that time truly matters. It took this country over 2 decades to figure out how to do a lockdown drill. It took this country 2 decades to figure out that in Columbine, if you wait for your SWAT team to assemble, no matter how sophisticated, it's too slow. And they moved to the protocol of 1+1 for Newtown Sandy Hook. And in Parkland, as you know, first up, first in. The combination of great concern is around guns and around the mental health of this country in many different domains. I think part of that has to be putting the team together locally that makes a difference. I stood in front of safety officials, public safety officials, and I shared with them that if they do not have a partnership with their school leadership, either they or that superintendent needs to leave because they have no plan. A safety plan, through my lens, is a plan that's always, always moving forward. Anybody who tells you that their plan is complete, that's when they're in trouble. So how does your research influence that district team? How do you get the critical pieces that you're discovering to local school districts? And how does that happen sooner than later? Time is treasure. I talk about team members quite often when I speak across the country. And whether it's public or private, whether it's higher education or preschool, it makes no difference. It's all the same plan. And how do we prepare, and what do we do? And how do we respond? The piece that I could spend hours talking to you about, and I'll take a minute, are the solutions that are in place. And where I developed my solutions were from the survivors of Sandy Hook Elementary School. I sat with them for 4 hours on a given day. And very similar to this conference, it wasn't about the media. The doors were closed, the coffee was warm, and the emotions were filling the room. And we talked about simple solutions. Yet those solutions have yet to play across this country with any fidelity at all. Simply locking your door. That was on top of the pile for Sandy Hook. Every classroom door in this country needs to be able to lock from the inside. Pretty simple. Yet there's tens of hundreds of thousands of doors still where folks have to go out in the hallway. Time is treasure. Number the outside of your building. Time is treasure. Someone take ownership. When I speak to school leaders, I speak to an audience where they're nodding their head yes, and I challenge them not to leave the information in the car or on the plane. And who's in charge of school safety in local communities? Who's in charge? I asked the question to school superintendents, do you have an athletic director? And guess what? Every hand goes up. And I asked the same question, do you have a security or safety director? And guess what? About 2/3 of the hands don't go up. So where are our priorities, and how do we reconstitute in order to be a safer community and a safer country? Last thing I'd like to share with you is what I think is most important. That's around courageous conversations. And much of that has to do with gun control and gun safety. I encourage every school leader never to make that decision in isolation. I encourage all voices to be a part of that conversation. I encourage that through a community conversation in every local community. Is there a need for an armed or an unarmed officer? And who should carry in a building? And who shouldn't carry in the building? I have some real strong feelings, I won't share them this morning, around teachers carrying weapons. But there's millions of federal dollars right now being spent to train teachers to do so. And how are we spending our money? The second great lesson learned throughout this country, I believe, is that we spent billions of dollars on post-mortem safety measures, surveillance cameras, metal detectors. This is the future, folks, and there is such a need for your information to come forward to public school leaders and private school leaders and school leaders across the country. I just want to, if I could, underscore for you the importance of what you're doing, how privileged I am to be here, and I share with you my contact information. Unfortunately, the cell phone number, I spoke in Vegas 2 weeks ago and my phone was stolen as I was speaking, so I do have a different number. If you want my cell phone number, just see me during a break. I'll be more than happy to give it to you. But that's my contact, my direct connect for my email. I love to carry on the conversation, and again, I am just incredibly privileged to be here and to be a part of this conversation. Thank you so much.
We are entering the question and answer part of the first session, and I think Lynn is going to read us, or Eleni, yes, they're going to ask each of the panel members, and there's a push button. Okay, great.
Okay. Hello. Okay. This is a question probably for Cheryl. Sorry. Were Native Americans included in the focus groups in the Upper Peninsula? And if so, has any information been gleaned regarding cultural beliefs around firearm safety and injury prevention in those communities?
So we haven't conducted the focus groups yet, but our intention is to include members of Native American communities. And I think probably in a separate focus group or two, although we haven't actually finalized that, and some of it might have to do with feasibility. But definitely a strong interest. I think people are probably aware that firearm suicide is a fairly high rate, higher in our rural communities than other communities in the U.S., and that among youth, the highest rates of suicides are among our Native American youth.
And what is the role of active shooter drills in schools? What do we know, if anything, about the effect of this practice on children?
First, we know it's very controversial, and that it's encouraged. I'm going to give you the 4 examples to answer the question. On 12/7/12, a week before the Sandy Hook crisis, the principal, Dawn Hawksprung, who was the first to be killed at Sandy Hook, she led a drill for her kinders and her first graders. And she shared with her kinders and first graders, if there's ever a bad thing happening in the building, run out your classroom door, run down the hallway, go through the double doors, and keep running. And I know that there was pushback from parents about, oh my gosh, this is just way too much for kinder and first grade. I also know that in reunification in the Sandy Hook Firehouse, when over 30 parents were standing believing their child wasn't coming out, that the 12 students, when the semi-automatic rifle froze, went out the door, down the hall, down a path to safety. I use that example often. There's great pushback right now in regards to a growing number of parents believing that there's a better way to train. I continue to believe that I'd rather have that conversation with parents and make sure that every child knows of the opportunities in regards to an active shooting drill than to allow people to move away from that drill.
Great. Thank you. Do you think that we'll start to see a decrease in warning signs prior to school shootings in an effort to hide intent now that see something, say something is being taught in schools?
Justin, can you repeat that question?
Essentially, do you think students will be trying to hide their intent and there will be fewer warning signs to report now that this program is in place and kids are aware of it?
I actually wonder if it might be the reverse. And so if you make signs and symptoms salient, do we expect to actually see an increase at first before you might start to see a broader change that might have an effect in actually reducing the number of violent events? But I believe it could be that you're making people more aware. We're hoping to actually increase reporting so that we can be in more preventive, rather than reaction.
Great. And another question about the Say Something program and early outcomes. So far, what is the level of consistency, or what's the level of consistency that students have accurately identified risky behavior related to possible violence? This question asker was worried about the possibility of targeting and inappropriately labeling students of color, for example.
So a lot of the signs and symptoms that they're trying to identify are based on previous literature. So we're looking for the examples that they will use are postings where there are specific threats. They're looking for signs or symptoms of internalizing behavior or depression. So they are trying to draw from examples that are literature-based, evidence-based, and would be applicable to almost any students that are not specific to a particular demographic base. But there does seem to be some, at least, recognition, again, from just more initial training, like immediate recognition of signs. We do see an increase. We've tried to include additional non-examples to see if people are just ticking off, this is an example, this is an example, this is an example, to see if we're actually recognizing fairly consistent signs that you might see.
Great. I think that's the questions we have for this panel. And just a reminder to everyone to send in your questions during the panel. Next panel. Thank you.
Great. Can everybody give a round of applause for our panel, please? I think that was a really great session, and as I reflect on it, I'm struck by not only the breadth of the communities that are affected by child and adolescent firearm injuries, but also the range of solutions that we see, everything from environmental design in urban settings to harm reduction strategies, working with partners, and upstream school safety interventions. And really, as you heard, about the urgency of translating these things into our school settings. So our next session is going to be the morning poster session. So the posters are located both along the hallway outside as well as here inside the room. And the next session will start back promptly at 11 o'clock.
Yes,